Thank you. I'm glad for this opportunity to talk to you about MDMA and psychotherapy and maybe help to allay some anxieties and answer some questions about what this work actually is. The media has certainly picked it up, and we see all kinds of claims for it, and certainly there are a lot of benefits that are possible. And I also want to talk about both the caveats to its use, but also the exciting possibility for trauma survivors for whom the regular therapy and regular psychiatric treatment certainly offers a very limited amount of success in relieving their symptoms. So I was one of a team who was involved in the MDMA-assisted psychotherapy research in Vancouver from 2013 to 2015. We originally had approached Health Canada to start this process in about 2009. So that gives you some idea of the 3 to 4 years it took us to jump all of the hoops that Health Canada wanted us to jump through, particularly the hoop of where to store the MDMA, which went to extraordinary lengths where we had to have a safe, cemented to a floor, covered by a cupboard. And at one point, I actually was in Ottawa and went and met with, the team of people really looking at the use of, illegal substances. And when I was talking to them about the MDMA and that really we were only going to have about 9 grams, a very small amount, and all of this concern about its storage when it could be in the safe with the opiates at the pharmacy. We had a pharmacy who was willing to do it. And I was amazed with this young person, and forgetting that I'm from Vancouver, where really, you could buy ecstasy on most street corners. And she looked at me very seriously and she said, "What if it got into the wrong hands?" And in fact, there was another funny piece, because for the study itself, I used to have to drive to the pharmacy from where we were doing the study to pick up, the little bag with the MDMA tablet in it. And they wanted me to be sure not to take the same route. I guess and somehow I was going to be followed. Anyway, it was frustrating, and now we can laugh about it. So the study was sponsored by an American organization called MAPS, which is the Multidisciplinary Association for Psychedelic Studies. It's a privately funded organization in the States. And there is now a MAPS Canada as well. And that's the organization that put the protocol together for the study, of many psychedelics, but particularly MDMA. And in 2005, they began the first MDMA-assisted psychotherapy research in the United States. So Dr. Michael Mithofer, a psychiatrist, was already doing the work in the United States by the time it was decided that we should also start a trial here in Canada. So the aim of it was to do this phase 2 study, which has to do with, there were 4 teams of therapists actually, and then a smaller number of patients, really looking at the safety of MDMA in a therapeutic setting, safety in terms of physical health for the participants, but also looking at some extent towards efficacy. Now that the phase 2 study has been completed, the next step is to do the phase 3, which will be probably 40 therapy teams, and over 200 subjects will be treated. And that will be the clearest statement of the efficacy of MDMA, and hopefully the move then towards legalization. Now, I also want to tell you that I've been working with trauma survivors, as mentioned, for over 40 years now, and certainly came up against the limits of what can be done in a regular psychiatry therapy office with people suffering from severe PTSD. And the study the subjects we had for the study were people who were considered treatment resistant. And there's a score called the CAPS score that measures PTSD symptomatology So we had to accept for the study people who had a very high CAP score. So the point in the research was to look at people that were severely symptomatic and severely limited in their lives by their PTSD symptoms. I mean, what I found in the office, that the therapy in fact took years. Someone with severe childhood trauma, there was a long period of really getting trust and establishing a rapport with the person, and then there was the very careful work of really uncovering what the trauma was. I mean, I know there are now, therapeutic modalities where the belief is that the trauma should not be addressed, that it is re-traumatizing, that the work needs to be in, lowering the symptoms and handling symptoms and behavior on that level. But my sense is that the trauma needs to be addressed in a safe setting, gradually, with a therapist that is experienced and with whom the patient-client has good rapport, and also where there is a real commitment to see this therapy through to the end. The whole issue of trust for the trauma survivor is huge. So for me, working in the office, I looked at art therapy, hypnosis, a variety of modalities to work with trauma survivors, and found that really there was a place where we could go no further, that approaching the trauma could be done up to a certain point, but then anxiety, terror, fear would overcome the person and they would block. And so therapy was always very difficult to move past certain areas. So in 1986, a friend of mine had experienced a method called holotropic breathwork, which you also mentioned. This is a method developed by a psychiatrist called Stanislav Grof, who's from Czechoslovakia. His original work was with LSD psychotherapy when it was still legal. And he was doing that work in Czechoslovakia and then was brought to the United States to bring this form of work and take his research further in the United States. The main tools of holotropic breathwork are music, intense music, and fast breathing. And with the person lying down, with those two, the music and the fast breathing, the person does move into an altered state of consciousness. When I just say that to you, you probably think, what the hell? But in fact, you would be amazed how, again, it's done in a group setting, safety is paramount, there really is a lot of work involved in setting the stage for this particular work, and people are partnered, so they're never alone, and they do enter an altered state of consciousness. I was just at a training for the phase 3 MDMA work, and one of the things that the whole group did was holotropic breathwork. And people who had never experienced it, a lot of whom had, of course, used a variety of psychedelics for their own learning, and particularly in preparation for working with MDMA in this study, they were amazed at the depth to which they could go simply working with the breath and with music, and really could see that there were other ways to move into the unconscious that does not involve taking substances that are still illegal at this time. There are certainly some people trained in this method. With my partner, we did holotropic breathwork from about 1990 to about 2014. These would be weekend groups or 5-day workshops. And I found that we really could move past those places where the blocks would occur in the office. So the average person there did the bulk of their work in about 3 years, which for those of you who know you've worked with people with severe PTSD, that is quite a remarkable piece of time. It wasn't that other therapy for other issues didn't occur later, but it was quite remarkable from my experience to really know that we could offer this. So now I want to say a few words about MDMA. I'm going to read you its full name because I get tongue-tied. So it's methylene dioxymethamphetamine. It's not actually a psychedelic because you do not hallucinate, you stay in touch with reality, it is not sedating, it is not, the mind is clear, but there is a different intensity in terms of seeing the world and then a shift into, a different state of consciousness. Really, it should be called, MDMA should be called an empathogen because of the opening of empathy that happens with this medication, or an entheogen, which is another word for producing a non-ordinary state of consciousness. I also want to say that it is pharmaceutical-grade MDMA that's used in the study. The drug that people buy as ecstasy often is a mixture of other things, often amphetamines, sometimes dangerous substances, and from sort of random testing of some of what's bought in the streets, probably the MDMA dosage in it is about 80 milligrams. The substance, the pure MDMA that's used in research is 125 milligrams. So for the therapy, the person gets 125 milligrams by mouth. They've been fasting. And there's a very rapid tolerance developed to the actual effect, that sort of heart-opening, fear-reducing effect of the MDMA, so that after about an hour and a half to 2 hours, the person is offered another half dose, 62.5, just to prolong the experience and to prolong that therapeutic window that's opened by the MDMA. So what MDMA does, it inhibits serotonin reuptake, which is something that SSRI antidepressants do, and it induces a large release of serotonin, which is where there ends up being the concern for depletion of serotonin, and it also induces the release of dopamine, which is what a typical amphetamine will do. There's also a release of oxytocin, which is involved in childbirth and is probably part of the bonding experience that people can feel with MDMA. So, the effect of MDMA. In the therapy session, it's a very specific experience. I mean, people who do it recreationally, with their friends, certainly have that experience of feeling relaxed, more open. There is greater empathy and ability to connect, and usually people have a very wonderful time. In a therapeutic setting, when you're working with someone with post-traumatic stress disorder, often it is not really an ecstatic experience. I mean, ecstasy is a tricky word to use in this context. But what it does do, what MDMA does, is stop the neurophysiological ability of the brain to experience fear. And what you know with PTSD is that it really is overwhelming fear and terror that leads to that inability to sometimes remember much of the trauma, to be able to approach the trauma in a therapy session, and be able to talk about it. People block, they dissociate, they may want to go further, but they really cannot. And what MDMA does is open up the therapeutic window where without that level of fear, people can move into talking about, seeing, assessing, remembering more about the whole context of the trauma in a way that they could not, without the support of this medication. The other thing that MDMA does is very quickly increase the level of rapport and trust with the therapist. Obviously, to do this work, you need to have established some connection with the person in the first place and get to know their history. I mean, the good psychotherapy does not leave the room when you give somebody MDMA. All of the things that you would do with someone that you're working with psychotherapeutically needs to all be there with MDMA as well. So you've taken a good history, you've established some relationship, some sense of what kind of areas the difficulties are and where the trauma may be. But with the MDMA, the sense of rapport and openness between, the person and their therapist opens up to a far greater extent. And it's where you as therapists need to be very clear and not afraid in being there, because the subject will pick up if you're afraid or if they go into an area that is too disturbing for them. So a person doing this work needs to be very prepared to be able to be open and fully present for whatever comes up for that person in the work that they're doing. Like, you can't fool a patient who's on MDMA about that you're comfortable when you're not. It really it shows. So there's the increase of the therapeutic alliance, and there's also a big increase in the person's self-acceptance. There's a diminution of shame and a diminution of self-criticism. So to be able to talk about something that is shameful, which is often present in terms of self-esteem or in terms of the actual details, for instance, with sexual abuse, the person can really feel that this is an event that happened to them, but they are not the ones that need to be ashamed. And it leaves a lot more room for working with what happened rather than the person going into hiding. I mean, the other thing that the MDMA provides is really a corrective emotional experience. With the MDMA, even on a physical level, some subjects will have the first experience of really feeling relaxed in their bodies. I mean, they feel that as the MDMA is coming on. There may be a little anxiety initially, but there is a feeling of warmth and relaxation, really for someone who may have been tense probably a large portion of their lives, or certainly since the trauma. So a feeling of the body being able to let go is, it's a very powerful experience for them and for you to really see someone who may have come in frightened, held, timid, and you can just see the body relax and then being able to expand into really looking in a much broader sense at what their life has been and what happened. It's also a time of a lot of human-to-human connection. Working with someone with MDMA, you have to be willing to touch. And so the establishment of boundaries, and you say all of this to the person before the session. You may, if you don't want us to touch you, say so. Although usually people, once they're in that relaxed, accepting state, when they're fearful, they will reach out a hand. There's a lot of physical contact, and with some people there's a point where really they want you to hold them, curl up in your lap, and so you can see that it's a very different situation than what happens in an office. That it's that loosening of boundaries and that availability of their unconscious material, their human need, becomes there in a very immediate way, in the therapy session. Plus, they may be reliving their trauma like it's going on in the room right now. And the trauma, the perpetrator might be there, the bomb may be going off, 9/11 just happened 5 minutes ago. So, again, as therapists, you have to be prepared for some very naked emotion and very naked, re-experiencing. Now, I want to refer to an American woman psychiatrist that some of you may know called Judith Lewis Herman. She was a professor of psychiatry at Harvard and wrote a wonderful book in the 90s now called Trauma and Recovery. And she talked about there really being 3 phases of therapy with the trauma survivor. Obviously these overlap and each happens in varying lengths of time. But the first issue is the establishment of safety. So that has to do with the location, the relationship with the therapist, really knowing that there are clear boundaries, and a sense that the therapist is really there, committed to their therapy as much as they are, that they're not going to be abandoned, that there's someone there who's ready to hear what their trauma was. And here you can see, since I mentioned the increase in rapport and trust that happens with MDMA, the move into that kind of level of trust happens much more quickly with the use of the MDMA in the MDMA session. The second phase she calls remembrance and mourning. So this is the phase of starting to remember the trauma itself and the various episodes of it, and then to mourn the horror of it, but also the losses in their life. And, you know, for instance, I'll talk about it in more detail, but the therapy protocol that we worked on was the meeting of the person, and the model is working in a dyad, so the male and female therapists, interviewing the person, meeting them several times. So there's a beginning of knowing their history and establishing some connection. And then in the session itself, there would be 3 MDMA sessions 1 month apart. And each session was 8 hours long. So the person would be given the MDMA in the morning, and then so we as therapists would stay with them for 8 hours. And it was during that time that they would go into memory, out of memory, into memory and emotion. So you can see 8 hours is a very intense, you know, therapeutic period. And, you know, the study was actually double-blind, so there were people who received an inactive placebo. I mean, obviously, both for the person and for us, you know, you very quickly could see who was not on MDMA, but nevertheless, you know, being with a therapist for 8 hours is still a pretty powerful, is still a pretty powerful emotional period with a lot of learning involved. So for the study, people had 3 MDMA sessions 1 month apart. And I would say in that 3 months, you know, the amount of revelation and learning was, I don't know, what you would do in the office sometimes, it might take you 3 years to do, if ever. So, you know, what you can see is that really the whole process is sped up considerably with the use of the MDMA. I mean, in regular practice, you wouldn't necessarily, you know, do the MDMA sessions a month apart. That's what the research protocol required. And you may decide to do more sessions. Most people felt after the 3rd session that they would have benefited from a 4th. But, you know, what you could see is that the MDMA, with that increased therapeutic window, there was really the ability to deal and remember much more quickly than, you know, in small doses in the office. And, you know, with these sessions, and particularly with that much opening, the follow-up is critical. You know, we would do a phone contact or an in-person contact with everybody for the 7 days after their MDMA session. After that 8-hour session, they would stay overnight in the facility, and then we would meet with them for 3 hours the next morning. So there has to be lots of room for really processing just in, you know, regular state of consciousness what had happened the day before. I mean, people are clear enough that they remember a lot of what did happen. I mean, 8 hours is a long time, so it helped that we kept some notes, plus for the research, everything was videotaped as well, but it was useful for them to also have some record of what had happened. And in Judith Lewis's Herman's 3 stages, the 3rd stage is reconnection with the world. And, you know, with the MDMA, there's a little bit of that starts to happen. Because as well as having periods where people are remembering their trauma, in between that, there are periods where they sort of relax. And in fact, it's kind of funny. And at that point, you do kind of feel like you're in a room having a drug trip. Because they joke, they want you to sit on the bench. They're lying down for the session. And, you know, some very sweet moments happen that really are just, you know, human to human, warm and laughing, and then something else, you know, may start to emerge. The sessions also, there is some use of music, which the person can either accept or they may want the music turned off. You know, if people are starting to get just too confused, sometimes to say to them, you know, just close your eyes, go back inside, go back to the music, also gives them the opportunity to reconnect with what is happening inside, and then speak about it when they're ready. You know, the therapy itself is really meant to be non-intrusive and mostly supportive of what is emerging from the person. Things, you know, the material emerges pretty spontaneously. You know, there may be a place to ask a question or two, but mostly it's a fairly spontaneously produced experience. It also can be that someone really goes into a lot of silence. And one of the women that I worked with, that's what happened. She really stayed silent or listening to the music, and all we could do was really check in every half hour or so and say, how you doing? And she would say, fine, I have no words. So sometimes that's what the session is, and that's what you work with, and then you see what emerges the next day with the processing. I do want to just address a few of the concerns about the actual substance of the MDMA. As I mentioned, the phase 2 study really was mostly to do with safety for the person, as well as a little bit about efficacy. So during the research, you know, there's increased heart rate, increased blood pressure, and increased temperature. So for the first, I can't remember, 3 hours or so, and maybe for the first hour, like every 15 minutes, we had to take a temperature, a blood pressure, and a heart rate. So all of that really settles after about the second hour, and people's temperature goes back to normal, their heart rate goes back to normal, they may have dilated pupils initially, and there's jaw clenching. That seems to be a fairly frequent side effect. But because what you hear about and some of the deaths that have occurred with MDMA have been mostly in party situations where people are dancing in a very overheated room, and either they do not drink sufficiently, or the other risk is they drink too much and end up with low blood sodium and passing out. You know, so you hear of fatalities of these big parties, you know, with the use of MDMA. But the thinking and the research seems to show that a lot of these events have been because the MDMA that was taken really was mixed with other kind of substances. So certainly in, you know, an average setting or a setting like a therapeutic setting, there is no physical risk. There's no danger of the person taking the MDMA. You know, the issue of addiction to MDMA, people talk about people getting addicted to MDMA. You know, that entheogenic opening quality really starts to diminish if you take MDMA a lot. So I suspect when you hear of young people taking MDMA every weekend, they're really mostly taking an amphetamine. And a lot of the energy and the, you know, the whole atmosphere has to do with them being in a party setting, and that's the setting. And how much of it had to do with the drug is really questionable. So of itself, there is no way of getting addicted to MDMA. And as I mentioned, there is no permanent depletion of serotonin, and also there was literature about, you know, holes in the brain and the effects of MDMA, permanent effects of MDMA, and really none of them have been borne out. You know, a lot of cognitive function tests have been done with people who have been frequent using of MDMA, and there really is no evidence of brain damage. One thing I should mention, because MDMA does affect serotonin metabolism, often if it's taken by someone who's on an SSRI antidepressant, what they'll find is that there may not be very much effect, because the SSRI binds to the sites at the nerve ending and really stops the MDMA from acting at that nerve site. So I've told you a little bit about really the structure of the research. You know, the 8-hour session, the overnight, every 3 sessions, 1 month apart. And I have to say that the follow-up is really critical. That, you know, the therapy is intense and there's a lot that opened up, but the subjects that, two of the subjects that we worked with, I think they would have had their last MDMA session in 2015, and I am still seeing them. Things have changed dramatically, and they, certainly that whole thing of reconnecting with the world and reconnecting with their work cells, although it may be in a different area, is gradually happening. But there's no way that MDMA is a magic bullet. You know, it certainly speeds up certain aspects and makes possible certain parts of trauma therapy, but on its own it does not. And I think that's probably where you hear of people having bad experiences on MDMA, is because really something else is opening up and they're not in a setting where they can really deal with it. The problem is not the drug, the problem is something they're carrying, you know, in their psyche. So with the research, I mentioned the CAPS score earlier on, that was the score that was used, as well as obviously the history of the severity of their PTSD. And then the CAPS was repeated after the second MDMA session, then 2 months after the third, and then again at a year later. And I can report that at the 2-month point and at the 1-year point, the improvement, the subjects were no longer within the range of PTSD. This occurred for 68% of the people who had those 3 MDMA sessions, which I think is pretty remarkable, because basically it means that happened in approximately a 6-month window of therapy. And this is for people who have been in other forms of therapies as well. So it's, you know, you may have seen higher figures than that in the very first, Dr. Mithofer's work seemed to imply a higher figure than that, but I think the figure is probably going to be in that range of 68%, and certainly with the improvement holding, and for some people even more improvement at that 1-year point, that the shifts that start with the MDMA continue in that positive direction. But in terms of the experience as a therapist of working with someone with MDMA, I think I've alluded to some extent already. You know, there really is an intensity and a real emotional rawness in being there, you know, with that person. So I would say you really need to be prepared and experienced to be present for that level of trauma and expression before entering into this kind of work. So, and I think, you know, a real attempt is being made for people to be trained as psychedelic therapists, and not to be the automatic assumption that you can move from one therapy into this level of work. And the other thing that I think is a fabulous preparation for working with psychedelics is a holotropic breathwork that I mentioned to you earlier. Because I'd had over 10 years of really working with people in those non-ordinary states, you know, being with someone, you know, with the MDMA, it felt like they had, the holotropic breathwork session is about 3 hours. So being with them in 8 hours, it sort of felt like, you know, you did 3 or 4 breathwork sessions back to back. There's that kind of intensity, and the work just keeps on moving, you know, for those hours. For those of you, I'll just make a little plug here. For those of you interested in holotropic breathwork, in fact, in November there will be a workshop. There are flyers at the back there where Stanislav Grof will, on the Friday evening, will be streamed in by video. So there'll be as talk by him, as well as by myself and another woman psychiatrist, and, you know, Carolyn, who's here. All of us have done breath work for many, many years now. And then on the Friday night and then the Saturday will be a chance to really experience, you know, the breath work yourselves. I know when I've been here for, you know, the Psychedelic Psychotherapy Forum that's occurred here a couple of times in Victoria, I've had psychiatrists come up to me and say, what do we do in the office? You know, we've come this far and I can't get any further. What can I do? So it's a burning issue. Plus, when you look at what's happened to war vets, to firefighters. I mean, there are a lot of people walking around with PTSD, and there really is a limit in what we can do for them, or the therapy is so long that it's really hard to have enough therapists to really be there, you know, for these people. I'll mention one story of one man that I worked with. He'd been one of the people at 9/11 who went to the site to really look for bodies after the crash of the World Trade Towers, and he was severely traumatized by this. And partly, I mean, there were many things, but one of the things was the searching for bodies that they couldn't find, you know, because there'd been such a conflagration. And what he came to realize is that what was hard for him was when his shift ended, leaving that whole area of the World Trade Center and having relatives and friends searching, looking, hoping that it was one, you know, they'd be holding up photographs, sort of hoping that one of their relatives had been found. And, you know, his trauma had been around, you know, the bomb and loss and, you know, the planes and so on. But for him to realize that this other piece was also, you know, one of the hardest things for him, really shifted his PTSD symptoms and his ability then to mourn and move on from that. He'd actually had to leave the United States and gone to live in Hawaii because he really couldn't stand traffic, smoke. You know, his life had really been, you know, damaged by his exposure. And then when I met him a few years later, and you could see what a difference the MDMA work had done for him, that he was back in the States, he was working and had a relationship. So it's remarkable what a shift a session well handled, or several of them, could make for these people. One other thing I want to mention is that there's also, you know, the really exploration of using psychedelics for work with people with addictions. And what I would want to say is that this work with MDMA and trauma needs to also inform that work with addictions. That I think a lot of people with addiction histories, or with, you know, moving into substances as a way of handling their symptoms, really do carry a trauma symptom beneath. So I think anybody who moves into doing psychedelic work with people with addiction really need to know that there'll be a certain percentage, and probably a fairly large one, of moving into having to do trauma with these people, maybe before their addiction, but, you know, for some people what happened to them as their lives disintegrated. So this whole area needs to be, you know, well known by people working with psychedelics. So I just wanted to mention the caveats again, that there's lots of promise in this area, but the caveats I've already referred to, that psychedelics are not a magic bullet, that psychotherapy really needs to be part of the whole therapy before, during, and after, that the establishing of rapport is really an important part of allowing that therapy to move through and to be accessed, and that the need for integration and, you know, the person then coming back into the world, reconnecting with the world, as Judy Lewis-Soman would say, is a big part of the work as well. As some of you may know, there is a phase 3 study that's now being planned. So that will be about 40 therapy pairs, probably seeing over 200 people, with majority of teams in the States, probably 3 in Vancouver, maybe 1 in Montreal, and then some in Israel. So there are the caveats and the promises and the experience.